Yeah, welcome again. I'm going to introduce our panelists to you today. And again, thank you for joining us with our panel discussion titled Best Practices for Implementing User Access Monitoring Systems. We have a great lineup today. My name is Mickey Jernigan, and I'm the SVP of Privacy and Compliance and Chief Privacy Officer at Genzeon. And I'll be your moderator today. Joining us as panelists are Ashley Brown, the Director of Compliance and Privacy at Anderson Healthcare. Ashley is a seasoned HIM and privacy professional with over 12 years of experience in the field. She holds a Bachelor's of Science in Health Information Management and an RHIA from MoHIMA. As an active leader in MoHIMA, the Missouri chapter of HIPAA, Ashley has served in various volunteer roles since 2019 and is currently in the position of president. She's led numerous EHR and software implementations in her career. In her current role as Director of Compliance and Privacy at Anderson, she oversees the organization's compliance program, leads initiatives to safeguard patient information, ensures regulatory adherence, and fosters a culture where compliance and privacy are at the forefront of decision-making. We also have Amy Cordray. She's the Chief Privacy and Compliance Officer at UC Health in Cincinnati, Ohio. She has been a licensed attorney for over 25 years, working in both private practice and as in-house counsel. Today, she plans to contribute a dual perspective on user access monitoring, drawing on her extensive experiences in both healthcare privacy and compliance. Also joining from UC Health is Fred Bishop. Fred has nearly 30 years of IT experience. He's currently the Director of InfoSec and has been an information security officer for over 10 years. In addition to UC Health, he's had the honor of working in the healthcare space since 2001 for Alliance Behavioral Care, an MBHO owned by the University of Cincinnati Department of Psychiatry, and in 2006, the Linder Center of Hope in Mason, Ohio, where as the Director of Information Management, he was responsible for architecting the LCOH computing environment, including applications, databases, IT infrastructure, and IT security. Last but not least, Amit Kulkarni is the founder and CEO of Intruno, Inc., a leading provider of patient privacy monitoring solutions with a comprehensive GRC suite. With over 24 years of experience in technology leadership and computer network security, he holds multiple patents and is recognized as a visionary in AI, data privacy, and compliance. Amit is a frequent speaker at industry conferences and will be presenting on AI and its ethical use and compliance at the upcoming HCCA CI in Las Vegas on April 28th. Today, we're going to get started with a polling question. And our first polling question is, do you have an existing user access monitoring system? Of course, easy as yes or no, or we're trying to advocate for it. Unfortunately, Sarah, I cannot see the results of the poll.
It looks like had about they're still coming in, but majority of it looks like seems like yes. Got a couple no's, and there's at least one trying to advocate for it. So got a good mix here.
Yeah, absolutely. A great mix of all perspectives. And so hopefully we'll have something for all of you, those who have done it before, those who don't have it yet, and those who want it. Hopefully those who don't have it yet will understand and be able to advocate for it very soon. There's the results. Okay, fabulous. So we're going to start. My first question is for Fred. Insider threats usually account for a very high percentage of incidents. So Fred, how have insider threats evolved in healthcare And it's a two-parter. And why is user access monitoring critical in mitigating these risks?
Yeah, so just like our threat actors from the external side are continuing to get more sophisticated, I think our internal threats are also getting more sophistication. They are aware that they're being monitored potentially, and we'll potentially try to use techniques that might avoid direct detection. So I think it's important as healthcare entities that we continue to step up our game in trying to monitor and be aware of those types of insider threats. And having a system that can help identify that risky behavior more easily, more quickly, with a higher degree of accuracy is a great step in helping improve that process.
Great. Thank you. Amit, what would you add to what Fred has shared?
Sorry, I was on mute. Well, originally coming in from the security side of things, to complement what Fred said, yes, definitely the traditional systems are there for the external side of things, but insider threat can be even more disastrous because insiders have a lot more access. Outsiders, they have to navigate through various different hoops and jumps, and they have to find vulnerabilities. In this case, it's essentially an open access, and if they're not monitored, entire patient population can be dumped. So that's a huge risk.
Absolutely. And as a privacy officer, Amy, what would you say are some of the common gaps organizations fail to address when monitoring user access? And this could be with or without an EHR monitoring system, but specifically with that monitoring system.
I think that what we've learned most recently is with the EHR monitoring system is that users are getting, they're sophisticated and they're getting creative with, like Fred said, they know that they're being monitored. And so we've noticed that they are, we see a lot less of the direct patient lookups in the EHR, and what we notice is they're starting to use things like bedboard hover actions or inpatient list loading. Often you can't limit what inpatient lists that the team has access to, and so they will often load inpatient lists that all of them, and look for people or individuals that they should not be looking at that way. It doesn't happen often, but when it does happen, we notice that they're getting more and more creative with those things. We've also started, I think another gap that we've noticed is you really have to pay attention and track patterns of your users and learn what is normal behavior and what is what's out of step for somebody. So we really try to pay attention and look for those abnormalities in what people are doing.
Ashley, same question for you as a privacy officer. What gaps do you see either in your experience or you've read about or you've heard from colleagues that those insiders often navigate around perhaps, or that healthcare organizations need to have a better pulse on?
Yeah, I think some of the gaps that we've seen, or I've seen personally, what are all of our bolt-on systems and making sure that our access logs are showing, we have our main EHR, but we have another platform that shows our radiology images or our cardiology or anesthesiology, and making sure that while we have the data pretty available for our main EHR, that it's also there and available for all of those bolt-on applications. And sometimes that can get pretty complicated because the technology, like Fred mentioned, is just moving so quickly that it's difficult for some of those legacy systems, I think, to keep up, and that they can kind of all be integrated and work together so that the data just kind of flows seamlessly from going to one software to the other software. And similarly to Amy, one of the other things that I've kind of noticed is employees accessing the census or who's in the waiting room, things like that, that the access logs might not always be to the granularity or the detail that we need. A lot of times the users already have access and they're permitted to have that access, but the detail of what exactly they're clicking on and what exactly they're viewing sometimes isn't there.
I was actually talking to another colleague yesterday, and something you mentioned, Ashley, about all the bolt-on systems, that was their concern, is that they had monitoring on 2 of their main EHRs, but none of their other systems. And that's where they felt their biggest gaps were too. And so that's couldn't be more relevant. Somebody I just talked to yesterday. So, Amit, what about, I know we've been talking about insider threats and gaps. I know things are top of mind for you and probably Fred too, but I'll start with you about cybersecurity threats to user access monitoring systems. How do they support or help prevent those cyber attacks?
In regards to cybersecurity threats, we need to identify which patients' records or which systems are exposed to the outside world, right? Usually we have, if you have an Epic system, you have MyChart or some other patient portal. But when it comes to clinicians or practitioners who are caretakers, they need to get into the application, put in patient notes, clinical events, prescriptions, and so on. So that particular access needs to be monitored. And how are they getting in? Do they have the right authentication, 2-factor, multi-factor, and so on? So in regards to even that needs to be audited. So, but it needs to be proactive as well, not after the fact.
And Fred, what would you add to that about cybersecurity preventative measures?
Yeah, definitely making sure that your perimeter where access is occurring from remote locations has been secured as much as possible. Minimize IP address ranges if you have the ability to work back with your security teams to restrict access from IPs that originated from Russia and China. I know that what we do is we limit all offshore IP addresses and only use exception-based access when appropriate, so that we can really minimize the exposure we have from a lot of threat actors who are operating outside of the United States IP address space. Now, that doesn't cover all the threats, but it certainly helps reduce some of them. Another thing to make sure is even for your patient access portals that you have some level of monitoring or capability to understand when access looks inappropriate and then are able to react to that as well. We've actually added to our cybersecurity incident response plans that include what happens if there is some sort of compromise to our patient portal, and how are we going to react to limit the exposure related to that. So just being aware of all those different avenues of attack, potential exposure, and making sure that you have either controls in place to help reduce the likelihood of compromise and response plans that are geared towards that type of event, so that you know what to do in advance of it having it happen.
We do have a hand raised from the audience, so I'm gonna take the Joe, I'll allow you to come off mute.
Okay, thank you. Fred, regarding what you just said about the portal, I often ask I'm a consultant, and I often ask my customers about, how they try to secure it and everything. And it's always kind of they're always at a loss. And I don't have any really good suggestions either. But give me an example of the kinds of abnormal behaviors you might see with the patient portal, because those I haven't really seen any yet. So could you give me an example?
Yeah. So first of all, don't forget that call that comes in from somebody that may or may not be the actual patient. So that can certainly be an avenue of attack. So making sure that if you have your help desk or your service desk for your patient portal, make them aware that there can be calls that come in that are not from the actual patient whose account they're asking for. There can also be, there are other, a lot of IT teams use, oh shoot, I'm trying to think of NetScalers, for example, to help protect the environment. So that could be a source of logs. If you're seeing a lot of the same IP address hitting the patient portal, that might be an indicator that someone's trying to, do a dictionary attack or some other type of password attack against that site. So those are the kinds of things that you not necessarily are getting directly from the portal, but there may be other tools that are in your arsenal that can monitor that. Another thing we do to help lock down our patient portal is, I mentioned, the IP address exclusion. We don't allow IP addresses from outside of the United States to access the patient portal. We do have a alternative method for access that we do provide to patients who might be traveling abroad and need access to it. But that is a different mechanism than direct access to the patient portal. So there are ways to help reduce the risk. You can't eliminate it, obviously, but there are definitely some different opportunities. And I would encourage working back with your IT departments and your security departments to ensure that you've thought through all the different ways that you can protect the patient portal.
Okay. So many of my customers have vendor hosted patient portals, and so they're kind of at the mercy of what the vendor has in place. So it's nice to have some examples of things they could be talking to them about. So thank you for that.
And one quick
And-
other tool to add to that list, Joe, is a web application firewall. So if you add that in front of any internet exposed application, whether it's a patient portal or a payment system or anything, so that WAF, web application firewall, will eliminate traditional attacks, known pattern dictionary attacks, as Fred was mentioning.
And Joe, to add to what Fred and Amit have said, that would be something that your customers should be talking to the vendor about during contracting phases. And if they already have a vendor, then during their annual renewals or their biannual renewals, whatever those are definitely security features that they should ask that the vendor has. So I think we are ready for our second poll question. If you are actively using a user access monitoring system today, which the majority of our attendees are, how closely do you work with your IT security team? These are some great answers. We are besties. Only as needed, or we have an IT security team.
Well, it looks like generally people know they have an IT security team, so that's great. Good to know. All right.
Oh, yes. This is a very high percentage. 67% answered we are besties. So that is fabulous. Please continue that relationship, especially if you're on the privacy or HIM or compliance side, because in my past experience, I've had almost no better partner than my IT security director. So make sure that if you don't have that relationship, that you do develop it, because it will help you as a privacy, compliance, or HIM officer grow in your role too. So with that said, I'm going to start with Amy. What key elements should be included in a robust user access monitoring program?
To keep building on that idea of relationships, because my IT team, or information security team, we're besties. So we go bowling together at UC Health. So But to continue to building on that, I think it's really important. Our team works really hard to ensure that we foster relationships and collaboration across all departments. So we work really strongly and intently with HR, with our frontline leaders, with our physicians, our GME office, our legal and our risk management teams. Like, we try to really ensure that we involve all necessary parties at all times, to just keep the process moving and to ensure that we are responding adequately and in real time. The other piece that I would say that's a key element would be to have consistent and repeatable meetings, regular meetings. And then in addition, we will add ad hoc meetings, in particular when we have a proactive media event, or we have something else. We don't let things sit. We don't let things wait. We are consistently proactive and meeting in real time and keep things going.
Okay, great. So Ashley, in your experience, and it doesn't have to be from your current employer, because I wouldn't ask you to expose things that shouldn't be exposed, but what are some real world examples that you're aware of user access monitoring actually detecting and or preventing a security or privacy incident?
Ideally, your system would provide you some flags, those that are using a system for access monitoring, if they have event lists and such as that they could hopefully identify. One of the examples, we have a report that shows us if you're accessing someone that lives within like 30 miles of the employee's home address. So if you might be snooping on a neighbor. We also have reports that show us if you access an employee's record, somebody that might work on the same unit as you do. And of course, all of that is driven by our payroll system. So that's another kind of layer of complexity, that your user access system has to have that connection to your employee data to see those types of things, which can be difficult sometimes to get depending on who your payroll system is. But those types of things is what we have seen that our system can catch ahead of time based off of address or employee relations, patient relations. Sometimes if the contact or emergency contact is listed on a patient's record, we can identify if somebody is looking at a family member that way, if they have any sort of relationship or status. We've also seen where parents are paying the bills of their adult children, and so we can look to see if parents are accessing their child's record, even though the child has reached the age of majority as well.
Great. Amy, what would you share about that? What, as in your experience as a privacy officer, what types of situations have come across your desk, or have you suggested your access monitoring system actually put in a check for?
I'm drawing a blank on what we have suggested. I know we have sent suggestions, but I'm drawing a blank on what those are. Things that we do though, are that some examples. I know we often, I'm drawing a blank, sorry.
I can hop in if that's
That's
okay.
okay.
Yeah, because I'm drawing a blank, sorry.
You guys
I don't
are
know what's throwing
besties.
me off.
Yeah, I think
That's all
Fred
right.
could probably.
If you start talking, then it'll jog my memory and I'll start talking then. How's that?
Right, yeah. I mean, there are tools both within your EHR potentially that can help limit access, like break the glass, for example. You can change the username or the patient name or pseudonyms for folks that might come in as high-profile patients, and then also be aware of like your VIPs who obviously they draw more attention than the average patient, and they may be a VIP because they are coming in from a very newsworthy event. And so those are opportunities to identify users who may be interested in snooping those patients. And then there's some techniques that you can use once you get information back and you're doing some analysis of patient access or user access of patients or specific patients. We actually use, we export the data and then we use Excel to help filter and look at the types of access that are occurring for various departments, right? So should an OB/GYN user be accessing a male patient, for example? And there may be reasonable reasons for that, but then there may not be. So it's those kinds of understanding of how the clinical operations work, where they should be. If you're a multi-site facility, do people from a different facility, should they be accessing patients in the other facility? And again, there may be reasons for having the access, generally speaking, within that particular organization. But is that access appropriate for that particular situation? We also use color coding and we'll pivot on potential violations and run additional reports that are specific to that user if we do identify an unusual access by a user. And those pivots will help us see sort of longitudinally in time, what other access was that user doing and all of a sudden they've jumped to something completely different. Then that also helps, identify some unusual behavior. So there are a lot of different techniques and certainly, not limiting yourself to those can be helpful. We've also used like security video camera footage, tap badge access, things like that. Your parking systems even we've gone to. So again, fostering those relationships with those other departments in your organization, and letting them know there may be times that you're going to come calling, asking them for some specific detail on a particular situation will help allow you to be able to get that information in place.
So as a follow-up to what Fred shared, Amy, when we do find these unusual patterns, I'm guessing that you either work very closely with IT security or privacy takes over the incident investigation. And then I can let you, if you wouldn't mind, describe what that investigation looks like based on that information.
Yeah, a lot of times, well, it depends on what's happening. Sometimes my team will take it over. Sometimes we will still work hand in hand. We will take those pivots that Fred talked about, and we'll scrutinize those, looking for where is that individual? Are they outside of their normal work hours? What's their computer location? Where is that computer located? Sometimes that we can tell, sometimes we can't. So we might work back with Fred's team to tell us, are they a remote worker? Or are they if they're on campus, where is that computer located? Because Fred's team knows exactly where that computer is at, based upon its name, its host name. We can also, we also look at, we prevent data download, so we don't really see anything like that, but we might see, are they printing something? Have they printed? We really look at it from a lot of different angles. And then eventually we get to the point where we will talk to the manager and with HR, and then they really will talk to the individual. We don't really do that portion of it, but we're always available if they need us.
Wonderful. So we haven't mentioned it today, but I know AI is on everyone's mind all of the time, whether it's, yay, we can't wait for it, oh, I'm terrified, or somewhere in the middle. So Amit, what role does AI and other automation play in enhancing user access monitoring efforts today?
In regards to AI, it really starts with the data. The amount of training data that you can feed to the AI, it's not a black box that you send it and forget it. It has to be continuously cured and supervised, as well as there might be false positives. You need to essentially dismiss the false positives, send a feedback to the system so that it gets auto-corrected, and for future and continuous use, you have lesser and lesser false positives. So I mean, any organization which deploys AI-based tools, they should not consider them as cookie cutter solutions. They, you deploy them, and it does definitely need some handholding initially.
Great. Well, one thing we haven't talked about yet on elements or things that play into a robust user access monitoring program are policies and procedures. I think we've touched all around them, but I'd like to ask you, Ashley, about how organizations can ensure that their user access policies or policies related to user access stay compliant with HIPAA and other healthcare regulations.
I'm fortunate to have a couple of vendors that provide me with updates to policies and procedures whenever regulatory changes occur. So that's super helpful. But just staying mindful of what's in the news and what changes are happening and making sure that you're reviewing all of your policies and procedures. A lot of places do it annually. We typically review ours every 3 years. And unless something changes or comes up that would warrant us to review, we're always looking for lessons learned. So anytime a policy is relevant to any sort of incident or investigation, we're always pulling our policies and reviewing and adjusting them at that time based off of any of our lessons learned. But I guess the best thing I could say would be to watch out for the regulation changes and making sure that you are updating them as you're seeing those things come up.
Thank you. So, Fred, should organizations conduct a risk and gap assessment before implementing user access monitoring solution?
Yes, I mean, one of the things you need to do is know what your environment looks like and where are those gaps so that you can focus on a solution that will, most readily address those. Everything, been doing security for a while now, so everything you view, everything you do in the world, not just within healthcare, but everything is a risk, right? And so you have to measure what is the most likely risk and then go after those first. With of course the impact piece also factored in there, right? So having a process that you can reliably repeat to analyze and look at what your risks are in your environment, and then making sure that you're following that, and not just initially, obviously the selection of a solution that matches your particular gaps is great, but ongoing, right? You need to be aware of new gaps that may develop as a result of new threats and new vulnerabilities. And so keeping an eye on those as well, and making sure that you're communicating back with your solution vendor so that they're aware of changes in your environment and have an opportunity to address those changes over time also will help in making sure that those gaps stay minimized.
Great. Sarah, do we have any other questions?
None that have come in so far.
I see some in the chat. I think they're in the chat instead of the Q&A.
Oh, there you go.
Yeah. So I think one of the questions, and I'll give this one to you, Ashley. Have you heard of any uptick in inappropriate access to, specifically the question is women's reproductive health history, but as we all know, the definition is so broad that it is not limited to females. So have you seen or heard any of that?
Yeah, that's a timely topic, right? I haven't yet, interestingly enough. That in my experience, that all kind of came in and worried everybody in the beginning because we haven't seen any changes in a while to the privacy rules. But kind of in like a lion out like a lamb sort of thing, that I haven't heard much about it since. It seems like everything's going fairly well. I don't know that we don't have any controls in place to necessarily flag us for something access such as that, just because, like you said, Mickey, the definition of reproductive health maybe a little intentionally vague. So, and especially with the complexity of our EHRs, would be way too difficult to flag something like that. It goes as far as it could be birth records could be reproductive health, and of course all the way up through adulthood. So that's difficult to track and flag and do any automation on that.
Absolutely, and it includes things that are so broad that most people wouldn't even guess. So, it includes things like your, male issues as well, not
Mhm.
just female, anything to do with the
Right.
reproductive system. What
Yeah,
about
right.
you?
I was gonna say, for birth, child, a baby circumcision is even in that definition. And so that's something that we have to educate our providers on, because like you said, a lot of people think it's just related to women, but it's male and female birth up all the way to death. So it's pretty extensive.
Amy, have you noticed anything or seen any articles about anything that might answer this question in a different way?
No, we haven't, I haven't noticed any, we haven't noticed any inappropriate access. Like Ashley said, we don't have anything that would flag that. So no, we've had other concerns, or issues to address with it, but not with regard to inappropriate access.
So
I would say, Mickey, sorry, that's probably also pretty hard to find, because most of the time I think when that rule comes into place, it's going to be something that falsely reporting, I guess you could say, or not kind of accusing an individual of wrongly having reproductive health care wrongly. So I don't know, the user who's accessing that record is probably appropriately accessing the record according to their job responsibilities, but it's that step further. It's not really the access to the medical record, but it's the actions that they do with that information that's really the issue, not necessarily the access.
agree, it's more likely to be found as a complaint-driven access versus just normal access monitoring because of the difficulty in flagging any of it, much less how difficult it is for ROI systems. So,
And Mickey, if I may add, from a
yes, please.
log management, from the audit log perspective, I mean, as Ashley and Amy correctly pointed out, that information doesn't transpire into the audit log, right? I mean, unless and until the metrics or the particular actions are specifically mentioning reproductive, or obviously we can identify who the patient is, male, female, but it doesn't get beyond that. So, unfortunately.
Agreed. Until the definition is restricted or more very specifically defined, it would be almost impossible to put a rule around it to flag access to a specific record.
Yeah, the best you'd have to do would be like access from your urology department or your OBGYN departments, so you could get some inferences, but they would be, indirect technically. So, but that would probably be as far as you could get without, nailing down which CPT codes, procedure codes, and then as Amit indicated, having that information flag and flow into your auditing system. So a lot of pieces have to fall into place to be effective at doing that.
So Amit, I think we have another question here. Let's see. Amit, I'll let you take this question. It is asking if Intruno or other systems include diagnosis codes in what is imported.
Traditionally, audit logs do not contain diagnosis or prescriptions or even CPT codes. So it's typically who the user is, who the patient is, what action was performed on the user, and it's more detailed systems like Epic will give a bigger description as well. But if it's a homegrown application or a smaller EHR, I mean, oftentimes we have worked with organizations and their vendors to create an audit log. Sometimes it's not non-existent even. So,
Like you're thinking, Joe. It's a good idea.
So, Ashley, I'm hoping you can answer this question, maybe not from personal experience, but just generally. Some of the biggest challenges, or just some challenges, that organizations face during the implementation phase of a new user access monitoring tool with their EHR.
I guess I would just have to go back to the complexities of all the bolt-on systems and making sure that it has everything in there. And again, linking with your payroll system for me personally was the most helpful to identify employee impermissible access. And depending on who your vendors are, that can sometimes be pretty complicated. We also have a wide variety of facilities. We're a healthcare system, so we have ambulatory and rehab and surgery centers and things. So the more facilities you have can sometimes make things a little more complicated also.
Those are all very valuable considerations. The size and complexity of your organization, as well as how many systems you have, will sometimes help you decide what vendor can provide what capabilities you need. Amy, how would you suggest measuring the effectiveness of your user access monitoring program post-implementation?
I think that you've got to look at, measure the corrective actions that have been taken over time. We look at, we have that reported back to us. We look at, initial warning versus written warning, terminations, everything. And we see, and we also look at, how many did we send that versus that turned out to not be something. We also look at the how many we closed internally that we didn't send to HR. So that something that came into us as an alert, maybe, but we actually didn't send it because we were able to identify that it wasn't a case.
Like for example, someone who was sourced to a different unit for a day or a week or something.
Yes.
That's one of the most common examples I saw, was that now normally they work in mother baby, but now they're moved to a different unit because of patient census. Yeah.
Yes, exactly. Yeah. And that happens a lot with like PCAs with us. We notice that a lot. But those are some of the things that we use to measure how effective we're being.
And I would think maybe you see an uptick in your initial implementation, and then it levels off maybe to somewhere probably not as low as you had before, but probably pretty close.
Yeah, there's a happy medium, right? When you where you've got to find that sweet spot between the program's working because you're getting a lot, and then you want it to level off because it's working because your training's working, right? And everyone's listening and following the rules. So yeah, you've got to find that sweet spot. It does take a little bit of time, but you'll get there.
So, Amit, what are some of the best practices that you tell your customers to employ for continuous improvement, even adaptation, in response to those emerging threats when they're using your user access monitoring system?
In regards to continuous improvement as I mentioned earlier, the feedback is important. One, it starts with, as Amy just pointed out, the HIPAA training. In fact, I'm dating myself, but when I was working at a large health system in Michigan, I used to do the HIPAA training and the HIPAA security training. It starts with that, and then once you have a tool in place, how do you keep that up to date in regards to identifying those investigations? Hopefully, people are not repeat offenders, and if they are, then there's a problem there. Either they didn't get the training or they just are just a bad apple, right? Thank you.
Fred, what would you add to that?
Well, I think one of the things is, again, looking at changes in behavior and trying to identify those, right? New features that come into your EHR lend to new opportunities, perhaps, to identify inappropriate behavior. The reality is that you can't monitor, you can't boil the ocean here, right? You can't cover everything. It's impossible to do that. So certainly as AI becomes more sophisticated and is able to help more readily refine your results and get you closer to positives versus false positives, taking advantage of that, the training, providing that feedback loop to your vendor, I think also helps. And that's really the goal here. It is, very difficult to be able to analyze all the data simultaneously. We may eventually get there with quantum computing and other future technologies where, it'll be like that. But right now, a lot of human interaction is needed to validate information, and there is only so much time that you can do. So again, going back to that risk analysis, making sure you're focusing on those gaps where you see the biggest risk, understanding those changes. So if you see an uptick in user self-access, let's say, or some other event that you're monitoring for, right? Try to figure out, well, why is that? Is there a new tool out there that's causing user self-access to occur? Is somebody messaging users, and each EHR is different in how it operates, but you can create situations by just the fact that new capabilities are being utilized by your workforce. So it's really understanding your environment and knowing how it's changing will help you with continuing to improve your accuracy and ability to identify the behaviors you're looking to identify.
In fact, adding to what Fred just mentioned, I'll give an example. One organization we were working with, they were having some kind of alerts where coworkers were looking at, employees were looking at coworkers' kids. Okay, so how do you identify that, right? So this is from a personal experience. I was at a community event, and there was a lady in scrubs with her child. She didn't know who I was and what we did, etc. So I was just casually asking, okay, so how do you manage your medical records, and what if you need to look at your child's records? So she's smart, and she looks at me, and with a smirk, she says, I don't look at my kids' records. I ask my coworker to look at their kids' records. So, there are these things you need to keep an eye out, and tweak the model, tweak the AI to adapt to these kind of people who are ready to bend the rules, if
I couldn't agree with you more, Amit. There are always going to be individuals or groups of people, for that matter, that figure out ways to get around the monitoring tool, whatever it may be, whether it's AI, in a system like Intruno, or just regular checks like our privacy officers might run. So yeah, the human behavior is something we will never be able to fully control. And, technically I'm okay with that, as a general aspect. But that's a great added comment. So we are close to time. I know we have set aside time for questions. We don't have any others in the chat right now.
Looks like Joe raised his hand.
Joe, okay, great. Joe, another question?
Yeah, sorry to be a pest.
Oh, no, we love it. Please
Okay.
engage with us. We absolutely appreciate it.
Okay. Amy, you said early on, I'm trying to look at my notes, see if that makes sense. You said that more people might be, more users are using patient list or inpatient list, did you say?
Mhm.
Offloading those. If that's the case, I was wondering, that's kind of where I was coming from with the diagnosis codes, but ICD and CPT codes, what if that were part of the data import, and then you look at that relative to those patient lists that they're generating, you might see some red flags there. They might be looking for something, whether it's reproductive health care or, I don't know, pick a diagnosis, pick a procedure. They might be looking at something that it's kind of like, well, they're not a researcher, they're not a physician that does that kind of service, or maybe they are. They're looking to see who their competitors are. It could be all kinds of things. So I was just curious, do you think there'd be any value to that? Just spitballing here.
So Amit or Fred might need to help me explain it technically, but when someone loads an inpatient list, we can see what inpatient list they're loading. So more often than not, for at least with our system, what they're seeing or what they're doing when they load an inpatient list, we can't control. Everyone has, it's permissible, the access they have to the inpatient list they have. And the list that they're loading may be by floor, or it could be by a team, like a trauma team or an ED team, the ED list, the inpatient list, like that's going to be transferred from the ED to inpatient. So they're loading, those are the lists they're loading, but the reason it flags for us is because that individual is not from that department. So we're saying, wait, why are they looking at it? Which then causes us to stop because we can see the inpatient list loaded, and then we can see each patient they've then accessed after that. So it does flag for us the inpatient list load, and we can see the data behind the name of that list. So that, I don't know how that goes, Amit, with what you were saying about I don't know where that fits in with, like, it's not a diagnosis code, it's not a prescription, it's not that. I don't know where that fits.
So in regards to, the inpatient, the patient list is there, but at the same time, the other thing we are also looking at is who is in charge of this particular patient? What does the care team consist of? And was this user or individual looking at that record part of that care team? So let's take an example of a patient coming into the ED. There would be a set of people working on that particular patient, but another coworker also in ED is just curious and starts looking at that patient's records, right? How do we identify that? So that it all relates to, the patient list may not help in that case, right? In this case, so we need to go one layer deeper to identify the care team and then find the outliers there. There are multiple ways. We continue to learn literally every day. And in fact, even during today's presentation, I already learned a few things from both of you, as well as Ashley.
To your point, Joe, I do think there's value in it, especially as a privacy officer. There's obviously some diagnoses that are extra sensitive, that we could maybe flag those and maybe monitor those a little more if that were an option. I think normally when I see kind of what Amy's explaining as the patient list come into place, it's where I'm looking at all access to any specific patient. And a lot of times I'll see some users pop up on there that don't make sense to be accessing that patient's record. But looking into it further, it's a little vague, but it's usually that person has ran a list or a report, and that the list may be of 1,000 patients, and that patient just happened to be one in 1,000 that was on that report. And it shows up as if that user had accessed that patient's medical record, but really all they did was run a report that patient met certain criteria. So that's kind of another challenge with the access reports. Then to Fred's point earlier, that you need to have that relationship with your ID department to kind of decipher and dig in further to some of that information.
Great.
Yeah.
I think we have a few hands raised. I'll let Sarah.
Yeah, so I'm gonna try not to butcher your name. Bo Bakar, I'll take you off mute if you wanted to. Oh, did you allow to talk? There we go. If you'd like to ask our panelists the question.
Yes, can everyone hear me?
Yes.
Oh, yes. Hi, everyone. So my question was in regards to self-access. If you're the privacy tool that you have, are you guys monitoring self-access? And if you are, how are you guys enforcing it? Is there a policy you have? That's because I know self-access, some systems allow, some do not. So I always like to ask around to make sure that if we are going to do it, just at least I can use you guys as a as a reference. Thanks.
I usually run a report based off of same last name, but as you can imagine, that gets pretty complicated, especially when my last name is Brown and so is a billion other people's. So that can get pretty cumbersome, but the address sometimes helps in those types of situations, or the person's contact, or maybe basing it off of a secondary data point like who's listed as the patient's guarantor. We can kind of run a report that says, show me everybody Ashley Brown, access Ashley Brown, but the guarantor also has to be Ashley Brown, or something to that effect. That will kind of narrow it down a little bit, but it's that's a complicated thing for me. I don't know if anybody else has any easier reporting.
So I can probably chime in. So I mean, in regards to self-access, so a lot of organizations do allow self-access or just lookups, right? The big red flag is, when people start modifying their own records. I mean, and what are they modifying? Are they modifying prescriptions, or codes, or their maybe changing out their medical records? What are they actually modifying? So I mean, if they're just scheduling an appointment, that's not as bad, right? But if they're doing something more nefarious or a fraudulent activity, that's the more concerning aspect.
And that's the just real quick, that is the problem with self-access. If you allow it in your organization, is now you have the Wild West, and unless you're really trying to drill into and find what it is that individual's doing, you don't know what's going on. So it's much better to have just a blanket statement. Listen, you've got your patient portal. You should be able to access all of your information through that portal now, right? There's federal law that requires that. So essentially, there's no reason, generally speaking, for an employee or a user to get into their own record, with a few exceptions, which would come up like they're the only person to check themselves in for their patient appointment, which you want your users and your employees to go see your providers, right? So there are some situations where it would be permissible, but you want to handle those as the one-offs rather than allowing, generally speaking, your users to access their records within your EHR.
Not to go too far into the privacy rules here, but also a lot of medical records it's not just your designated health record that's in there. I'm not going to go through those definitions today, but there's more in there that user is getting access to than just the record that they're really permitted to have access to. So that can become an issue too.
Absolutely. Well, I think we're just about at time, but speaking for myself and all of the panelists, we thank you all for joining us today. And of course, if you have any follow-up questions, please don't hesitate to reach out to any of us. And if you are looking for a user access monitoring system, of course, Amit is the person to reach out to. Intruno does that, and I think they do it very well. So I would definitely recommend you reach out to Amit if you need a new user access monitoring tool, or you just want to pick his brain about it. I'm sure he would make time for you to do that. Again, thank you all for joining us today, and thank you to all of our fabulous panelists, and for Sarah for handling all of the complexities behind the scenes for our successful panel discussion today. Thanks.